So about 3 weeks ago, a guy walks into my office. Let's call him David. 53 years old, runs a landscaping business, still very much in the game, still working with his crew most days. And he sits down across from me with this look on his face, this mixture of frustration and resignation. And he says, "Doc, my right knee has been killing me for about 6 months now. I figured it was just getting old. My dad had bad knees, my uncle had bad knees. I guess it's my turn." And I looked at him and said, "David, how old is your left knee?" He paused. He kind of laughed. And he said, "Same age, obviously." And I said, "Right. So if this were purely about age, both knees would hurt the same way, wouldn't they?" And you should have seen the look on his face. That one question changed the entire direction of our conversation. And honestly, it's the reason I'm making this video today. Because I hear some version of David's story almost every single week. Someone comes in, they've had knee pain for months, sometimes years, and they've already diagnosed themselves. They've already decided it's just what happens when you get older. And listen, I get it. That narrative is everywhere. Your buddy at the golf club says it. Your neighbor says it. Even some doctors, if I'm being honest, will kind of wave their hand and say, "Well, wear and tear, what do you expect?" But here's what I want you to understand, and I mean really understand, not just hear. That explanation is lazy, it's incomplete, and in many cases, it's flat out wrong. Your knee pain is trying to tell you something specific, and if you just chalk it up to age and move on, you might be missing the actual problem, the one that's fixable. I'm Dr. Callum Everhart. I've been in general practice for 17 years, and I've seen thousands of patients with knee complaints. And one thing I've learned is that the knee is not just a simple hinge that wears out like an old door. It's one of the most complex joints in the human body, and the reasons it hurts are almost never as simple as people think. So today we're going to go deep on this. I'm going to walk you through the real reasons your knee is hurting, the ones that have nothing to do with your birth certificate. We're going to talk about what's actually happening inside that joint, why certain activities make it worse, what your doctor might not be telling you, and most importantly, what you can actually do about it, starting this week. No jargon, no scare tactics, just the truth. And I think some of what I'm going to share is going to genuinely surprise you. Let's get into it. All right, let's start with the biggest myth, the one that drives me absolutely nuts. It's just arthritis, nothing you can do. If I had $1 for every time a patient told me a previous doctor said that to them, I could retire tomorrow. Now, let me be clear. Osteoarthritis is real. It absolutely exists. And yes, the likelihood of having some degree of cartilage change in your knees does go up as you accumulate years on this planet. That part is true. But here's what most people don't know. There have been multiple large-scale imaging studies, and I'm talking about studies with thousands of participants, where researchers took magnetic resonance images of people's knees. People who had zero pain, zero complaints, felt completely fine. And guess what they found? A huge percentage of those people had what radiologists would call significant findings: meniscal tears, cartilage thinning, bone marrow changes. On paper, their knees looked rough, but these people were out there hiking, playing tennis, chasing their grandkids around, feeling absolutely nothing. No pain at all. So what does that tell us? It tells us that what shows up on a scan and what you actually feel are two very different things. The image is not the whole story. And this is where so many people go wrong. They get an X-ray or a magnetic resonance image. The report comes back saying moderate degenerative changes, and suddenly they think their knee is falling apart. They stop moving. They stop exercising. They start babying that knee. And ironically, that's often what makes things worse. Because a knee that doesn't move is a knee that gets stiffer, weaker, and more painful over time. Now, if the scan doesn't tell the whole story, what does? Well, this is where it gets interesting. Let me walk you through the things that are actually driving most knee pain, and some of these are going to sound surprising because they have nothing to do with the knee itself. Number one, and this is probably the most underappreciated factor, is your hip. Specifically, your hip strength and hip mobility. I know, you came here to talk about your knee, and I'm bringing up your hip. But hear me out. Your knee is essentially a joint that's caught in the middle. It sits between your hip above and your ankle below, and it basically does whatever those two joints tell it to do. If your hip is weak, and by weak I mean the muscles around it, particularly the gluteus medius, which is that muscle on the side of your hip, your thigh bone starts to rotate inward when you walk, when you go upstairs, when you squat down. And when your thigh bone rotates inward, your kneecap doesn't track properly. It gets pulled to the side. It grinds against the groove it's supposed to glide smoothly through. And over time, that creates irritation, inflammation, and pain, usually right at the front of the knee or just behind the kneecap. This is incredibly common, and I see it constantly in people who sit for long hours at work. Their hip muscles basically fall asleep, and their knees pay the price. I had a patient, a woman named Susan, early 60s, retired teacher, who had been told she needed a knee replacement. She came to me for a second opinion. I examined her knee, sure, but I also tested her hip strength, and her gluteal muscles were shockingly weak. I'm talking she could barely resist my hand pushing her leg inward. I referred her to a physical therapist who focused specifically on hip strengthening, not knee exercises, hip exercises. 6 weeks later, her knee pain was cut in half. 3 months later, she was walking 2 miles a day with no pain. No surgery, no injections, just a stronger hip. Now, I'm not saying everyone's story will go that way, but the point is, nobody had even looked at her hip before. Everyone was so focused on the knee that they missed the actual cause. The second major factor is something I call the quad shutdown. Your quadriceps, that big muscle group on the front of your thigh, is the primary stabilizer of your knee. It's the muscle that absorbs shock when you walk, when you go downstairs, when you land from a step. And here's the thing about the quadriceps. It's one of the fastest muscles in the body to weaken when you stop using it. If you've had any kind of knee pain, even for a few weeks, there's a neurological phenomenon where your brain actually starts inhibiting that muscle. It's called arthrogenic muscle inhibition, and it's your body's misguided way of protecting the joint. The brain says, hey, that knee hurts. Let's not fire that muscle as hard so we don't aggravate it. But the result is that the muscle gets weaker, which means the knee gets less support, which means more pain, which means more inhibition. It's a vicious cycle, and it can happen remarkably fast. You can lose measurable quadriceps strength in as little as 2 weeks of reduced activity. This is why the advice to just rest it can be so counterproductive for most knee pain. Yes, if you have an acute injury, you twisted it, something swelled up overnight, a brief period of relative rest makes sense. But for chronic knee pain, the kind that's been nagging you for months, rest is usually the worst prescription. What you need is the right kind of movement, the kind that wakes that quadriceps back up and teaches your brain it's safe to use that muscle again. Now, let me talk about something that almost nobody discusses when it comes to knee pain, and that's your body weight, but not in the way you think. I'm not here to lecture anyone about their weight. That's not my style, and frankly, people get enough of that. But I do want to share a specific piece of biomechanics that I think changes how people think about this. When you walk on flat ground, the force going through your knee joint is roughly 2 to 3 times your body weight with every single step. When you go upstairs, it's about 3 to 4 times. And when you go downstairs or walk downhill, it can be up to 5 to 6 times your body weight. So let's do some simple math. If someone weighs, say, 200 pounds, and they lose just 10 pounds, which is a very achievable goal for most people, that translates to 30 to 60 fewer pounds of force on the knee with every single step. Over the course of a day, when you're taking several thousand steps, that adds up to literally tons of reduced pressure. Tons. And this isn't theoretical. There's a landmark study that followed people with knee osteoarthritis over 18 months and found that for every pound of body weight lost, there was a 4-pound reduction in the load exerted on the knee per step. 4 to 1. That's an incredible return on investment. And here's the part that really gets me. You don't need to lose a dramatic amount of weight to feel a difference. I've had patients tell me they noticed a change in their knee comfort after losing as little as 7 or 8 pounds. Not because the arthritis reversed, it didn't, but because the mechanical load on the joint dropped enough for the inflammation to calm down. All right, I want to pause here for a second. If you're watching this and something I've said has clicked, maybe it's the hip thing, maybe it's the quad shutdown, maybe you've had an experience with your knees that you now see differently, drop a comment below and tell me about it. Seriously. I read these comments and they help me understand what topics to cover next. And if you know someone who's been dealing with knee pain and just assumes nothing can be done, send them this video. It might genuinely change their outlook. All right, let's keep going. So we've covered hip weakness, quad inhibition, and body mechanics. But there's another huge player in knee pain that gets almost zero attention, and that's the health of the tissue inside the joint itself, specifically your synovial fluid. Think of synovial fluid as the oil in your engine. It coats the surfaces inside the knee, reduces friction, delivers nutrients to the cartilage, and helps cushion impact. Now, cartilage doesn't have its own blood supply. It gets its nutrition almost entirely from this synovial fluid, and the way it gets that nutrition is through compression and release. When you load the joint, when you step on it, squat, walk, the cartilage compresses and squeezes out waste. When you unload it, it expands and soaks up fresh fluid with nutrients. It's basically like a sponge. And this is crucial because if you're not moving that joint regularly, the cartilage isn't getting fed. It's starving. And starving cartilage breaks down faster. This is one of the most compelling arguments for consistent, moderate movement, even when your knee doesn't feel great. I'm not talking about running a marathon or doing heavy squats at the gym. I'm talking about walking, cycling, swimming. Gentle movement that takes the joint through its range of motion and keeps that fluid circulating. There's a concept in orthopedic medicine that says, motion is lotion. And while it's a bit of a cliche, it's actually deeply accurate from a biological standpoint. The joint literally needs movement to stay healthy. And this connects to another point I want to make about stiffness. A lot of people with knee pain tell me, "Doc, the worst part is the stiffness. First thing in the morning or after I've been sitting for a while, my knees feel like they're made of concrete. It takes me a few minutes to get going." And they assume that stiffness means damage. It doesn't, at least not necessarily. What morning stiffness usually means is that the synovial fluid has settled and thickened while you were still. Once you start moving, the fluid warms up, distributes, and that stiffness fades. If your stiffness resolves within 15 to 20 minutes of gentle movement, that's actually a pretty reassuring sign. It means the joint is responsive. It means it just needs a warm-up, not a replacement. Now, if that stiffness lasts more than 45 minutes or is accompanied by significant swelling and heat, that's a different conversation, and you should definitely have that evaluated. But the everyday gelling that most people experience, that's just your joint asking you to move. Now, I want to talk about something that I think is going to change the way a lot of you think about your knee pain, and it's a bit unexpected. It's about your sleep. Yes, sleep. There is a growing body of research linking poor sleep quality to increased pain sensitivity, and the knee is no exception. When you don't sleep well, and I'm talking about truly restorative sleep, the deep stages where tissue repair happens, your nervous system becomes more sensitized. Your pain threshold drops. Things that wouldn't normally bother you start to hurt more. And here's the kicker. The relationship goes both ways. The pain keeps you from sleeping well, and the poor sleep makes the pain worse. It's another one of those vicious cycles. I had a patient, let me call him Martin, 61 years old, came in with bilateral knee pain, both sides, that he'd been managing with over-the-counter anti-inflammatory drugs for about 2 years. We talked about his knees, we talked about his activity level, all the usual stuff, and then I asked him how he was sleeping. He kind of shrugged and said, "Not great, but who does at my age?" So I dug deeper. Turns out he was snoring heavily, waking up multiple times a night, and feeling exhausted every morning. I sent him for a sleep study, and sure enough, he had moderate obstructive sleep apnea. We got him fitted with a continuous positive airway pressure machine. Within 6 weeks, and he was stunned by this, his knee pain improved by about 40%. He hadn't changed his diet, he hadn't started a new exercise program, he just started sleeping properly. His nervous system calmed down, his inflammation markers dropped, and his perception of pain changed. That, to me, is one of the most powerful examples of how knee pain is almost never just about the knee. And that brings me to another factor that lives in that same category: stress and mental health. I know, you're thinking, "Come on, doc, my knee hurts, it's not in my head." And you're right, it's not in your head. The pain is real. But the way your brain processes that pain is profoundly influenced by your emotional state. When you're stressed, anxious, or depressed, and by the way, chronic pain itself is a major driver of all three of those things, your brain amplifies pain signals. It turns up the volume. There's a concept in pain science called central sensitization, where the nervous system essentially gets stuck in a high alert mode. Normal signals from the knee that should register as pressure or mild discomfort get interpreted as significant pain. And once that sensitization sets in, it can persist even after the original source of irritation in the knee has calmed down. This is why a purely mechanical approach to knee pain, just focus on the joint, ignore everything else, fails so many people. You can have the cleanest magnetic resonance image in the world and still have a knee that hurts if your nervous system is dialed up to 11. Addressing sleep, managing stress, Even something as simple as regular breathing exercises or a short daily walk outdoors. These aren't fluffy wellness add-ons. They're legitimate pain management strategies backed by hard science. Okay, let's shift gears and talk about some specific knee conditions that I think are worth understanding because knowledge is power, and when you know what you're dealing with, you make better decisions. First, let's talk about the meniscus. You have two menisci in each knee, the medial one on the inside and the lateral one on the outside. They're crescent-shaped pieces of tough, rubbery cartilage that act as shock absorbers between your thigh bone and your shin bone. Now, meniscal tears are extremely common, and here's the important nuance. Not all meniscal tears are created equal. If you're in your 20s and you plant your foot and twist hard during a basketball game, and you feel a pop and your knee swells up like a grapefruit within hours, that's a traumatic tear, and it often does need some kind of intervention, sometimes surgical. But the vast majority of meniscal tears in people in their 40s, 50s, and 60s are what we call degenerative tears. They happen gradually. Sometimes there's no specific injury you can point to. You just notice your knee starts aching or catching occasionally. And here's the really important part. Multiple high-quality, randomized controlled trials have shown that for degenerative meniscal tears, arthroscopic surgery, where the surgeon goes in with a camera and trims the torn part, performs no better than physical therapy alone for most patients. Let me say that again because it's that important. For most degenerative meniscal tears, surgery is no better than structured exercise. And yet, arthroscopic meniscal surgery remains one of the most commonly performed orthopedic procedures in the country. That gap between the evidence and the practice is something that honestly keeps me up at night. Now, I'm not anti-surgery, not at all. There are absolutely situations where surgery is the right call. A locked knee, a displaced bucket handle tear, a young athlete with an acute injury. But for the garden variety degenerative tear that shows up on an imaging study in someone with gradual onset knee pain, the evidence strongly favors trying a good physical therapy program first. And by good, I mean a structured program supervised by a physical therapist, not just a handout with stick figure exercises that you do half-heartedly for a week and then forget about. Second condition worth understanding: patellofemoral pain syndrome. This is the fancy name for what most people call runner's knee, though you absolutely don't have to be a runner to get it. This is pain at the front of the knee, around or behind the kneecap. And it's often worse going downstairs, sitting for long periods with bent knees, sometimes called theater sign, because it flares up in movie theaters, or during squatting movements. And this goes right back to what I said earlier about the hip and the quadriceps. Patellofemoral pain is almost always a tracking problem. The kneecap isn't gliding properly because the muscles controlling it are either too weak, too tight, or both. And the fix is almost always a combination of hip strengthening, quadriceps strengthening, particularly a muscle called the vastus medialis oblique, which is that teardrop-shaped muscle on the inner part of your thigh just above the knee, and addressing flexibility issues in the iliotibial band and the lateral structures. This is not a condition that needs cortisone shots as a first-line treatment. This is not a condition that needs surgery in the vast majority of cases. This is a condition that needs smart, progressive exercise. Period. Third, and this one flies under the radar constantly, is pes anserine bursitis. You have a bursa, which is a small fluid-filled sac that reduces friction on the inner side of your knee, just below the joint line. This bursa can become inflamed, and when it does, it causes a very specific kind of pain, a burning or aching sensation on the inside of your knee, usually a couple of inches below the kneecap, that's worse when you climb stairs or get out of a car. It's commonly mistaken for a meniscal tear or even early osteoarthritis. And here's the thing. This condition is strongly associated with weakness in the muscles I keep coming back to, the hip abductors and the hamstrings. It's also more common in people who have recently increased their walking or stair climbing. So someone who decides, I'm going to get healthy, I'm going to start walking 3 miles a day, jumps in too fast, and develops this inner knee pain, they often think they've damaged something, when really it's just a bursa that got irritated because the muscles weren't ready for that workload yet. Treatment: ice, relative rest for a short period, anti-inflammatory medication if appropriate, and then, you guessed it, a gradual strengthening program. I want to circle back to something I touched on earlier because I think it's worth really driving home, and that's the role of your feet and your ankles. Remember, the knee sits in the middle of a chain. If your hip affects it from above, your foot and ankle affect it from below. If you have flat feet, meaning your arches collapse when you stand, that causes your lower leg to rotate inward, which changes the angle at the knee, which changes how forces are distributed across the joint. I've had patients whose knee pain essentially resolved with nothing more than a proper pair of supportive shoes or a set of custom orthotics. I'm not saying orthotics are a magic bullet, they're not, and the evidence on them is mixed for some conditions. But for certain people, especially those with clearly visible overpronation, addressing what's happening at the foot can take a surprising amount of pressure off the knee. And while we're talking about footwear, can we have an honest conversation about shoes? I see so many patients, particularly women, who spend years in shoes with minimal support, thin soles, or elevated heels that shift their weight distribution forward onto the knee. And men aren't off the hook either. Worn-out work boots, completely flat dress shoes, old sneakers with the cushioning compressed to nothing. Your shoes are the foundation. If the foundation is bad, the structure above it suffers. I'm not saying you need to spend a fortune, but take a look at the shoes you wear most often. If you flip them over and the tread is worn unevenly, or if you can fold them in half like a taco, it might be time for a replacement. All right, let me talk about something that a lot of people ask me about: supplements. Glucosamine, chondroitin, turmeric, collagen peptides. The supplement aisle at the pharmacy is overflowing with things that promise to support joint health. So what's the deal? Honestly, the evidence is mixed at best. The largest and most rigorous study on glucosamine and chondroitin, it was called the Glucosamine and Chondroitin Arthritis Intervention Trial, or if I spell it out, the GIAT trial, found that the combination was no better than placebo for most people with knee osteoarthritis. There was a subgroup with moderate to severe pain that seemed to benefit, but the overall results were underwhelming. Turmeric, specifically its active compound curcumin, has some anti-inflammatory properties in laboratory studies, and there are a few small clinical trials suggesting modest benefit, but we're not talking about dramatic pain relief. In collagen supplements, the data is early and mixed. Some studies show a small benefit, others don't. Now, does that mean these supplements are useless? Not necessarily. Some of my patients swear by them, and I'm not going to take that away from anyone. If you're taking glucosamine and it makes your knee feel better, and it's not interfering with any medications, and it's not breaking the bank, I'm not going to argue with you. The placebo effect is a real, measurable neurological phenomenon, and sometimes the belief that something is helping you actually does help you. That's not nothing. But I will say this: if you're spending $100 a month on supplements while skipping exercise and physical therapy, you've got your priorities backwards. Movement is the single most evidence-backed intervention for knee osteoarthritis. Supplements are, at best, a supporting player. Let me talk about injections for a moment because this comes up all the time. Cortisone injections, or more accurately, corticosteroid injections, have been a mainstay of knee pain treatment for decades, and they can work. A cortisone shot can reduce inflammation and provide meaningful pain relief for weeks to months. But there's a catch, and it's an important one. Repeated cortisone injections have been shown to actually accelerate cartilage loss over time. A study published in the journal Radiology followed patients getting cortisone injections every 3 months for 2 years and found greater cartilage volume loss compared to those who received placebo injections. So while cortisone can be a useful tool for short-term flare management, say you have a vacation coming up and your knee is really acting up, it's not something you want to be getting every few months as an ongoing strategy. Then there are hyaluronic acid injections, sometimes called viscosupplementation, where a gel-like substance is injected into the joint to supplement the natural synovial fluid. The idea is sound: replenish the lubricant. But the evidence? The American Academy of Orthopedic Surgeons actually recommends against routine use of hyaluronic acid injections for knee osteoarthritis, citing insufficient evidence of benefit. Some patients do report improvement, but in controlled studies, the benefit over placebo is small. Again, I'm not saying never do it, but I want you to go in with realistic expectations and not think of it as a fix. The newer kid on the block is platelet-rich plasma, often abbreviated, well, let me just say, platelet-rich plasma injections. The concept is that you draw the patient's own blood, concentrate the platelets and growth factors, and inject that into the knee to promote healing. The early research is interesting. Some studies show benefit, particularly for mild to moderate osteoarthritis, but it's still considered experimental by most insurance companies, which means you're often paying out of pocket, sometimes several hundred to over $1,000 per injection, and the quality of the preparation varies widely from clinic to clinic. I tell my patients, keep your eye on this one. The science is evolving, but we're not at the point yet where I can recommend it with the same confidence I'd recommend a structured exercise program. Now, let's talk about what actually works. And let me be as specific as I can because I don't want this to be one of those videos where a doctor says, exercise more, and leaves it at that. That's useless. You need to know what to do. The gold standard for managing knee pain, especially osteoarthritis-related knee pain, is a combination of strengthening exercises, low-impact cardiovascular activity, and flexibility work. For strengthening, the key areas, and I've been hammering on these throughout this video, are the quadriceps, the hip abductors, the gluteal muscles, and the hamstrings. You want exercises like straight leg raises, wall sits, step-ups, clamshells, side-lying hip abduction, and bridging. You start at a level you can manage without significant pain increase, and I mean significant, because some mild discomfort during exercise is normal and expected, and you progress gradually over weeks. For cardiovascular fitness, the best options for people with knee pain are typically cycling, either on a stationary bike or outdoors, swimming or water-based exercise, and walking on flat, even surfaces. Walking is underrated. A brisk 30-minute walk 5 days a week doesn't just help your knees, it helps your cardiovascular system, your metabolic health, your mood, your sleep. It's the closest thing to a wonder drug that we have, and it's free. For flexibility, pay attention to the muscles that tend to get tight and pull on the knee. Your quadriceps, your hamstrings, your calves, and your iliotibial band, which is that thick band of tissue running down the outside of your thigh. Gentle, sustained stretching, holding each stretch for 30 to 60 seconds, done daily or at least 5 times a week, can make a meaningful difference in how your knee feels. And there's one more thing I want to mention that rarely gets talked about: the psychological component of recovery. When you've had knee pain for months or years, it changes the way you move. You start guarding. You start avoiding. You lose confidence in the joint. And that loss of confidence actually changes your movement patterns in ways that perpetuate the problem. You start limping even when you don't need to. You avoid stairs even when you could manage them. Your world gets smaller, and your knee gets less of the movement it needs. Part of recovery is rebuilding trust in your body, and that's a process. It takes time. It takes gradual exposure to the activities you've been avoiding. And sometimes it takes working with a good physical therapist or even a pain psychologist who can help you rewire that fear avoidance cycle. I also want to address a question I get constantly. When should I actually be worried about my knee? Because not all knee pain is benign, and I don't want you walking away from this video thinking every knee issue is just a matter of doing some exercises and getting new shoes. There are red flags. If your knee is significantly swollen and you didn't injure it, meaning it swelled up without a clear cause, that warrants evaluation. If your knee gives way, actually buckles under you, that needs to be looked at. If you have knee pain accompanied by fever, that's urgent. That could be an infection in the joint, and that's a medical emergency. If your knee locks and you physically cannot straighten or bend it, that needs attention. And if your knee pain is associated with unexplained weight loss, night pain that wakes you from sleep, or pain that's progressing rapidly despite doing everything right, please see your doctor. These scenarios are uncommon, but they're important to know about. Now, let me bring this home. If you've been living with knee pain and you've resigned yourself to it, I want to challenge that resignation. The research is overwhelmingly clear. For the vast majority of people with knee pain, there are meaningful things you can do to improve it. Not cure it, I want to be honest about that. If you have advanced bone-on-bone arthritis, exercises aren't going to regrow your cartilage, but they can strengthen the muscles around the joint enough to reduce load, improve stability, and decrease pain. And for many people, that's enough to get back to the activities they love. If I could leave you with 3 things from this video, it would be these. First, stop accepting the "it's just age" narrative. It might be partly age-related, but that's rarely the whole story. And the parts that aren't age are usually the parts you can actually influence. Second, movement is your best friend. Not rest, not supplements, not injections. Movement, done smartly and consistently. And third, look beyond the knee. Your hip strength, your foot mechanics, your sleep quality, your stress levels, your body weight, all of these feed into what your knee feels like on a daily basis. Address them, and you might be shocked at how much better things get. If this was helpful, I'd appreciate it if you gave the video a like. It genuinely helps more people find this content. And if you haven't subscribed yet, this channel is where I break down health topics the way I wish every doctor talked to their patients. Clearly, honestly, and without the unnecessary drama. I've got a lot more videos coming on topics just like this one. Until next time, take care of those knees and everything connected to them. I'll see you in the next one.